Okay, I'm mainly going to guide through this video. According to our worksheet that we had, we have a 17-year-old female admitted due to exacerbation of her asthma. She's in respiratory distress, continuing to worsen. The physician is intubating her and would like us to set up the ventilator. So what settings would work best? We are going to put the patient in pressure support. So we have our ventilator here. I already have this all set up. We have it plugged into the wall with our air and oxygen. And I already have everything hooked up to like our test lung. So we're gonna change it here. We want pressure. So we're gonna start out at FiO2 of 100, respirations 12. To kind of guide through it, you can just turn this knob up and down and then press in when complete. I time of 1 second. PIP here, we can probably just turn it down to 20, and we will have a PEEP of 5, but we'll watch for air trapping. Additional settings, we have our flow trigger of 2 liters per minute. So we're all ready, so then we can press this. So now we are in pressure control. So we can exit out here. Down here we have our settings. We can come over here to alarms that we want to set. Minute ventilation, like our high. Our current is only 6, so we can have a minute ventilation of 12. This can probably go down to, we'll do 35. High respirations of 24. Our tidal volume, we'll lower that just down to like 900 just to show you that. So we now have our settings all set up here. And then, of course, I have this hooked up to a test lung, but this will be attached to the being reset alarm right there. This will be attached to the patient. So the patient, we intubated her due to increased PIP, that we have increased airway resistance, and so we're just allowing this patient to rest and allow time for the steroids and other treatments to work. So the first task we have on hand is inline aerosol. So we use a mesh nib that goes in line here with the inspiratory tubing. So I had already we're just using saline. So we have saline hooked up in there, and our device is here on the side, and I already have that plugged into the wall. So what we're able to do is just turn that on. And then as we can see, our mesh nib, so it is just aerosolizing. And then I am able to switch to aerosol. So we know we are now delivering. And as you can see, every time the machine delivers a breath, you see that medication going in. So really there's no waste of medication, nor is there added flow so that our volumes are not getting altered. So we can just turn that off. I'm going to switch this back. So let's say the patient needed to do an inline MDI. We would take the canister that the aerosol comes in, and this is just our T-piece connected here. We're able to pop this top off and then put that canister right on it. So then when we do it, we are almost dispensing it. So we want to time this just perfectly while the patient is taking a breath. So we have this inspiratory hold or manually giving them a breath. So we can either wait for them to take that breath, like we can hold that while we disperse. So then the patient is getting that breath hold action in with the MDI. So you just kind of want to time it just right, disperse, breath hold, and then release. We don't use those that often just because we don't use MDIs hardly much anymore, but that is an option. So patient's doing good. We did a nebulizer, let's say bronchodilator, and then when we listen to the patient, they hear kind of coarse wheezes, and the physician has instructed that we do some inline suctioning. So the technique here that our manager had told us about was that, sorry about that, was that when you do this, you do not want it to get bunched up. So you need to have a technique that presses that in while not allowing that all to bunch up. You want it nice, and so you're gonna push that in and kind of bring back the extra, and then you're able to suction and pull it out. So that is the inline suctioning. You'll have it hooked up to your thing. I do not have that hooked up. So we have completed the suctioning, the inline aerosol, inline MDI. For cuff pressure monitoring, we do have this device here. I'm just gonna include it here to, so we have this, and we're just able to kind of read it when you press it in line with your balloon. Our director does not recommend us using this, just because every time that, let's say you have it set just perfect, by the time you take this off, it releases that little bit of pressure that could alter it. So instead, we would take a stethoscope and we would press this up against like the patient's neck, like that, and we would deflate the balloon until we hear a leak, and then we would adjust accordingly. That is just may seem like an easier option, but it's not as accurate as actually listening for the leak and adjusting the cuff pressure from there. So we have completed all that. So now we have come to our documentation. So here in ICU, we use a flow sheet. Kind of looks like this. Every time someone saves, it'll show up here. It has the times. You can click to find the date. So we click the ventilator here. So first of all, this would be probably right up in here. So you start with, what mode are we in? We are in pressure control. So you put PCU. Our rate set is at, I can probably, I don't want to type it in just because it'll show it for this patient, but we can go through and what do we have all set? All of our high and low alarms, our PEEP, our pressure support. What if IO2 do we have the patient on our inspiratory time? And then below that here we have our patient values. So this kind of just goes along right in with here. So we're able to just put all this information that we currently have here and place it here in our flow sheet. Then of course we're checking for our like FiO2, SpO2, our compliance, PIP, tidal volume, minute ventilation. We have our alarms here, our HME, our temperature. Did we suction? Yes, we did suction, so we put a Y there. So everything is here. We can look up the values, and it can show up our values exactly right here as we need them. Our heated humidifier, I don't have it hooked up, but it goes in right here, and it does tell us like a temperature here. what we want it set at, and then we'd put a temperature probe to make sure the patient is getting that adequate. We would listen for breath and lung sounds, watch for chest rise and fall, that they're bilaterally equal, just like our normal assessment that we would do with any other patient. And that is all I have.